Welcome to Function First Care podcast. It's so nice to have you here.
It's really exciting. I'm so privileged to have been invited, so thank you.
No, it's an honor to have you here. And we actually met virtually at one of the events of the Royal College of Occupational Therapy, in terms of kind of supporting independent practitioners with their kind of side hustles and with their independent practice. And I was really amazed by just hearing your journey, and we had a lot of similarities. And yeah, so I've invited you to come and speak on Function First Care. So, I would love for you to introduce yourself and tell us a little bit about your journey from occupational therapy and case management into women's health.
Well, it's been more than 10 years. So I'll give you a little bit of background. So I've been an occupational therapist for 34 years this year. And throughout that time, I've worked in the NHS, social services, case management, so voluntary sector, and charitable sector as well, and independent practice. So I've sort of pretty much spanned across everything in over 3 decades. And yeah, I was an advanced practitioner, case manager working in acquired brain injuries. And in 2012, I had my first gynecological surgery. So I'd had my second son in 2004. And increasingly over the next sort of 10 years, really, I was really starting to suffer with my women's health. So I was experiencing stress incontinence. I would have to adapt my routine. I couldn't go out having drank any water without knowing where the next toilet was. I certainly couldn't kick a ball around. No way could I jump on a trampoline. And it took 10 years before I plucked up the courage to go and see my doctor and say that I was struggling. And that's not uncommon. A lot of women will wait a very, very long time, hoping that it will get better. And it doesn't get better on its own. And yeah, so I had my first surgery, and that was a pretty major surgery. So I had a prolapse repair, and I had a TVT, which is a tension-free vinyl tape, which basically strings up the urethra to help, and the bladder to stop the incontinence. And that failed within 18 months, and it basically eroded through my vaginal wall. And went back to my consultant. He did a revision surgery. Within a couple of months, that failed. Went back again, sewed me up again, and then it failed again. And at the time, it was all hitting the news headlines about the use of mesh and how detrimental it was for women, suffering from pain and erosion, which obviously I'd experienced. And basically I was told pretty much it was my fault because of my tissue type, as opposed to actually it being a medical device that had gone wrong. So that was a really, really stressful time. So I had 3 surgeries within pretty much 2 years. And the stress of that situation was immense, and it triggered perimenopause. And my consultant at the time tried a couple of things, didn't try anything in relation to hormone replacement therapy. And menopause wasn't really talked about very much, even, just 10 years ago. So yeah, effectively, I was in a pretty bad way, and things were very dark. They were very difficult, and it's emotional talking about it even now.
Yeah, I can imagine.
But effectively, what it did my consultant basically tried a couple of things, and you know, well, one was antidepressants. I took one tablet and I had a horrific reaction. I had to ring my best friend and say, I don't know what to do with myself. Can you come and help?
Let me know
And
if you want a break on tissue,
yeah,
water.
no, honestly, I'm fine. Thank you.
And this is all about authentic, vulnerable, you know, raw
Yeah.
conversations. So let the emotions out, you know, it's
Yeah, it's
healthy.
important, and
Absolutely.
I talk openly about my
Yeah,
experience, because I think it's really important that women feel able to actually talk
absolutely.
about what they're going through. And you know, as a
Mm,
therapist, if I can't actually share my story, how can I expect my patients to share their story with me?
absolutely. Yeah. Thank you so
So,
much.
no, you're welcome. So yeah, it basically, my consultant threw up his hands one day and he said, Tracey, everything that I'm doing is making you worse. Go forth and find complementary therapies. And I just thought, well, I don't know where to start with that, you know.
Mm,
So even obviously as an occupational therapist, we're very holistic, but the holistic world, if you like, the complementary therapy world is quite different in a lot of
mm,
ways.
mm,
So yeah, I sort of thought, right, okay, well, what do I do now? And I
mm.
was really fortunate that there was an aromatherapy student studying in my local town, and she was looking for case study clients. And I just put my hand up and I went, oh, I'll be a case study. So I started going to see her every week, and that was a real turning point for me, because it helped to regulate my nervous system. It helped me to come back into my body. It helped me to calm down and to be able to start and see the wood for the trees and to get some clarity,
Mm.
because it's impossible to do that when you're in a heightened, vulnerable state. And it was funny because there was one week I just said to her, oh, I think I might train in this. And it wasn't that I wanted to be an aromatherapist, it's just that I wanted to learn more. And she said, well, why don't you? And the course that she was running was actually full for that academic year, and they only ran it every 18 months. And I thought, oh, well, by the time I qualify, I'll be getting on a bit. So I think I need to find a different provider. And I was fortunate that there was someone, a trainer in my town, who trained people in Swedish holistic massage. And I thought, oh, well, I'll do that, because it was about having a purposeful activity, something that was separate from work, something that would help to act as a distraction, but also just give me a different focus. And also, when you're training, as you know, you have to do case studies. So I had to do 60 hours of case studies. But you know, I also had the benefit of actually being massaged. So, you know, as your peers massage you and you massage them, and you get lots of practice in, as well as your case studies. And so that essentially what happened was I was seeing my case study clients, and they were all in a very sort of similar situation to me, all very dysregulated. Some were women, some were men, but you know, obviously the women were coming, they tended to be the middle-aged, you know, the midlife women who things were starting to feel a bit wonky. And I just had this light bulb moment of, oh, I can marry together my newfound, you know, complementary therapy skills with occupational therapy, because people needed more than just the positive touch. They needed someone to listen, someone to hear their story, someone to help give them strategies or advice or support. And it it was just, yeah. And so the plan had never ever been to set up my own business. The plan had been to help look after myself. And through that, I actually created Moth Therapies, which later became Moth TLC. So yeah, so a bit of a long-winded story, but obviously that's gone, you know, that's been since, well, before 2012, when, you know, I've been suffering for such a long time. And what happened was I started then going on a longer journey to discover other things that would then help me to be well. Because I didn't think that hormone therapy was suitable for me. And so I trained in aromatherapy and then meditation and hypnosis and, you know, lots and lots of things. But essentially everything came back to helping women, people with a uterus, who are struggling. And so whether that's with their pelvic health or through menopause, that's where my specialism lies, because that's been my difficult experience. And the last thing that I want is for people to have to go through that journey alone, which is exactly what I did, because there wasn't anyone like me back then who could provide the support. So
Yeah, love that. And yeah, like I said, thank you so much for being so open and vulnerable and, you know, sharing your lived experience, which, you know, you use in your therapeutic use of self, you know, in your practice, which I think is wonderful. And I think, you know, every therapist should do, because that's how we become more like enhanced you know, therapists, and we can really bring like that connection with our clients.
absolutely.
So absolutely, yeah. So by the way, yeah, again, if you need any time to stop or take a
I'm
break,
good.
then please do let me know. Yeah, we'll probably
I'll
both get the
wave a
tissue.
flag.
We will, you know, probably both get the tissues out. um yeah, so I just wanted to you know, this is what, you know, in terms of kind of hearing your journey again, it made me reflect about, you know, how I was so drawn to the fact that you kind of like had gone into learning and training on all these complementary therapies, which was similar to me when I was training as an occupational therapist. I trained in massage therapy, which was so beneficial in clinical settings. I've used it in, you know, in all types of clinical settings, including neurorehabilitation, and there's so much evidence for complementary therapies. And I do have an issue that is called complementary therapy because it sounds like it should be a side dish, but actually I do think it
Yeah.
needs to be integrated as part of the main dish, as part of mainstream you know, healthcare. So I just wanted to ask you, you know, looking back now, how did your own experiences with pelvic floor dysfunction, surgery, postnatal depression, and perimenopause change the way you think about health and rehabilitation?
No, I think for me, what it's done, it's made me even more client-centered. You know, and we
Mm,
talk about this term as OTs, don't we, about being client-centered, putting the client at the forefront of their treatment plan. But I really, for me, and I'm not saying that other therapists don't do this, but having gone through what I've gone through, I I have honed honed my skills for really listening with my
mm,
heart.
mm,
So it's not just about using our ears, it's about
mm.
using that empathy chip that we have, and we do
Absolutely.
have that as therapists.
Yes.
But having had that personal experience like throughout my reproductive life, and I hadn't touched on that and you've mentioned it, that, you know, throughout my reproductive life I've had PMDD. I had you know, when I look back, both my husband and I said we think that I had postnatal depression. Both times with my children that wasn't picked up. And see, look, I'm going again.
It's all right. Let it
Because
flow. Yeah,
yeah, it's, you know, I think as women we have so much
absolutely.
that we have to cope
Carry.
with. We
Mm-hmm. Yes,
carry so much, absolutely.
absolutely.
And I think I now have that privilege of being able to help, and I don't do this when I'm in sessions with people. I mean, occasionally there might be a tear, but you know, it's about really hearing empathizing and being able to hold space for people.
Absolutely.
And I've been gaslit so many times by doctors over the years, you know, not believing side effects from medications, not believing my experiences. And I think as occupational therapists, complementary therapists, whoever we are, but we are in a position of privilege, and being able to truly hold space for people and validate what they've been through is enormous. And let's
Absolutely.
face it, doctors don't have the time in their consultations to do that. But I think, you know, we do, and we also, as OTs, have that. We have that secret sauce, don't we? In that we're dual trained in mental health and physical health, but then we also add in our lived experience. Then, you know, we can just give so much to our clients.
Absolutely.
Yeah.
You're going to set me off, Tracy. We're going to be
send you a tissue down the ether.
We're going to be a wreck at the end of this podcast. Honestly,
let's make sure the listeners know that I'm sure it is going to get happier. Don't worry.
And we are, you know, it's just we're right at the start, you know, but it's, you know, it's just it's going to get.
It won't stay heavy, I'm sure.
But you know what, and it's absolutely fine, because these things, you know, all of these, this is like I said, a podcast that brings out a lot of emotions, because it is real, raw, vulnerable conversations. And, you know, and this is why, you know, I've created Function First Care, the safe space, you know, psychologically safe space to get professionals talking about their lived experience, because you know, that's not always seen and known when we are sort of, you know, caring and supporting our clients, you know.
Yeah.
And so this is why it's really important to, like, for us to talk about it, I believe. And like you said, you know, it helps kind of that to connect with our clients through our lived experience.
I think we've got a duty. We've got a duty to share our story.
Yes.
And especially as women, you know, women's healthcare is woefully lacking. And, you know, over the what are we now, 2026? So we're going back to 2012 when I had my first surgery. So 14 years. I'm back in the health system again. And by the time I get to see a specialist, it will be 4 years. 4 years since I went to my GP to say my situation has deteriorated and I need to be seen again. And yes, I've seen other doctors, but to get to the specialist that I need, it's you know, and that is just not acceptable.
No. And I know that a lot of our listeners will relate to this in terms of waiting times, and it's just not conducive to optimal health and well-being, which is why I'm really strong advocate for preventative healthcare, like, and education, you know, like, you know, because frankly, people don't have the time to wait around for, you know, but because our health and well-being will deteriorate by the time we've waited, you know, to get the support we need. So what was the turning point where you realized that regulating your nervous system, not simply chasing symptoms, was the key to moving forwards?
I mean, it was really early on, but I don't think I had that insight at that point that that's what was actually happening, because I was in such a distressed state that I was, you know, yes, I was going to work. I was doing the things that I needed, you know, to live, but I wasn't really thriving. I wasn't really living. I wasn't full of joy, you know. I was going about the motions.
Existing.
Sorry?
Probably existing.
Absolutely. You know, my nervous system was just, it was shut down. And so it was, I think it was when I started the aromatherapy, and as I then started to recognize that aromatherapy massage was helping me to, you know, find my baseline of calm again. Actually, this is what it feels like to be normal, inverted commas, you know, rather than being in fight or flight or being completely disconnected. And so it was then that I thought, this is the missing piece in the puzzle that no one is really talking about.
And you know, I was just reflecting when you talked about aromatherapy massage, there's that connection with not only human touch, which is really important, but nature as well, because obviously the essential oils comes from nature.
Yeah,
So there's all those aspects which sometimes can be missing from mainstream healthcare, you know. And but so I'm
absolutely.
so glad that you're able to kind of say from your lived experience, not only did you train in it, but you experienced, you know, the
Yeah,
huge benefits of it. And you know, and there is a lot of evidence around it. So why shouldn't we like integrate it as part of mainstream healthcare, and for people to know that there's huge benefits in this, you know, about the power of touch, the power of plant-based, you know, world and nature is beautiful, you know.
but
So
unfortunately, it comes down to money, doesn't it? It comes down to
mm,
money. The NHS don't have the money to be offering these extra specialist services, but in
mm,
some ways it's really short-sighted, because, you know, you talked about preventative healthcare, and you think,
yeah,
well, actually, if we can help
invest.
people to access these services at a very early stage in their mental
Yeah,
well-being or physical health, you know, journey, then actually, and education, of course, we may not get to this situation where actually they're needing to have surgery and long-term
absolutely.
rehabilitation, or carers coming in. So
And
it's
you
just,
save time and cost, you know, in the
yeah,
long term. So you know,
absolutely.
so obviously we've had a chat like I do with all my guests informally beforehand, and you often say you wish someone like you had existed when you were going through this yourself. What support do you think women are still missing today?
So I think it's about having someone actually that can walk along beside you. So not everyone needs a therapist or a counsellor, but to have someone that actually can effectively hold their hand, prop them up, just give them the leg up that they need at a time when they're vulnerable. And I
Mm,
talk about the 3 E's. So
mm-hmm,
like we have education, empowerment, and enablement. So I think, you know, I really needed someone that could have told me what was happening. Like,
mm-hmm,
let's go back to the basics, because my
mm-hmm,
consultant at the time said to me, oh, I think you're in perimenopause.
mm-hmm.
Well, what is that? He didn't explain what it was. He didn't give me a leaflet. He didn't signpost me to anywhere to go and look at a website or anything like that. So
I had the same a similar situation, by the way, when I was told that I might have suggested PCOS,
yeah,
and we can come on to that later.
yeah,
But I wasn't sort of kind of it wasn't explained to me, and that kind of support that I was looking for was missing, you know, for me,
yeah,
in my own experience. So yeah, sorry, continue.
yeah. No, it's fine. So like we're expected to know this stuff by osmosis.
Yeah,
And I mean,
yeah,
back in the day, women
yeah,
would have sat around the kitchen table, you
yeah,
know, chewing the cud, drinking coffee, sewing, doing all of those things, supporting each other within the community.
yeah.
And we don't have that now. You know, my
No.
parents live 330 miles away,
Mm,
and my mother never mentioned menopause. And when I
mm,
when I look back, you know, I remember her running off into the kitchen with sweat pouring out the back of her neck. I hope she doesn't mind me saying this,
mm.
if she watches what we're saying. But um, I didn't have a clue. She didn't tell me. She didn't mention it. And I
Mm.
talk to her now, obviously, because this is my area of expertise. And I said, why did you not talk to me about it? Why did you not tell me what was happening to you? Oh, I just had to get on with it. And
Right. Yeah.
and at the time, she went actually to her doctor. She had to
Mm,
sit in front of a panel of doctors who basically said
mm,
to her, "We want to give you antidepressants." She said, "I am not depressed. I need
mm,
HRT." I mean, we're going
mm,
back probably 30, more than 30 years, 40 years ago for her.
mm, mm.
And back then, that's what they were, how they were trying to treat menopause. And she says,
And
"I am
just so
not."
listeners know,
Yes,
in terms of
HRT.
abbreviations, yeah, HRT, if you could just elaborate on that just for
Yeah,
people who don't
hormone
know.
replacement therapy, or
Hmm.
you may see an abbreviation MHT, menopause
Hmm.
hormone therapy. So
Thank you.
they've been trying to change the term HRT to menopause hormone therapy, but it's not quite
Mm,
sticking yet. Everyone's still
yeah,
using HRT.
yeah,
Um, so yeah, so if you think, right, well, our generation, we're not even being guided by our elders,
mm,
because of culture or shame, or the fact that we're
mm,
disparate from our families, or we may have lost our, nearest relatives, our mums or our aunts, and so we've got no baseline to know where we start from. So, I think at least now that there is more information out there, thankfully, but still some women still don't even know where to go for that, and who to ask. So education is really, really
mm.
important, because if we have that information,
Yes,
then
yeah.
we're starting from a place of strength, aren't we?
Absolutely. And I think education, speaking on the topic of education, I really, really strongly believe that schools from a young, from kind of like,
Yeah.
from primary school, we should be talking about life skills, about life stages, and
Yes.
because then when you come out into this big wide world after, leaving school, you can it can feel really like intimidating. You feel lost, and
Yeah.
there's
Yeah.
so many different things that we weren't, I definitely wasn't taught like in school, and I don't know, because obviously you have children, so you probably know more about this than me in terms of, our schools teaching these things about life stages now, because I
They're
really
teaching the basics, but we can't
mm,
expect teachers to know everything. How can they
no,
possibly? I've spent
yes,
the best
absolutely,
part of 10, 12 years
yeah.
learning.
Mhm.
So how can we expect a teacher to be able to give the children all of the right information? I think we're
True.
expecting too much. They need to be bringing
Yeah.
people like me into the
Absolutely, that's exactly
school.
what I mean. Like
Yeah,
bringing occupational therapists, like, or other professionals to speak about life skills, life stages, and this is something I've definitely got on my list to do, to go out there and advocate and support people to really like learn these life skills and life stages. And
yeah.
yeah, so in terms of your journey, eventually it led you to the creation of therapies, as you mentioned earlier. So can you kind of like talk to people? I know that it kind of like it transitioned over to kind of another name. So it'd be good to talk about why you called it moth therapies, and the kind of like that abbreviation behind it, and kind of like
Yeah.
the terminologies of your companies. That would be great to hear about that.
Yeah. Well, Moss, and I've mentioned obviously that serendipitous moment where I thought, oh my gosh, I can bring together the different modalities to really support people, and I think everything that I do is always underpinned by occupational therapy.
Hmm.
Um, but so essentially, MOTH it's an acronym which in the early days stood for massage therapy, occupational therapy, health and well-being, and then it grew to encompass menopause and therapeutic coaching and TMJ therapy. But moth TLC, so if you like, I feel like moth therapies grew up a little bit a couple of years ago, and it became moth therapies learning coaching, so moth TLC, and that sort of signifies more around the services that I offer now. But more importantly than it being an acronym, it's about that symbolism of moving out of the darkness like a moth into the light, or like a butterfly. But
I love that. And actually, you speaking about a butterfly, and speaking about symbolism, um, I've just had, and I think this is, this is so timely that we're having this podcast today, because last weekend I was actually in the New Forest, and so many kind of things have happened since then, which I've talked about in my other podcasts that I've done this week, which has been around nature-based sort of occupational therapists, and yeah, the session kind of was facilitated by Maria Morris, Your Own True Nature, and I was actually sort of taken on this magical path, into my where I would be in my 6 months of my service in function first care. And when I was told to kind of sit down and imagine myself in 6 months on a bench, um, I then had a butterfly come onto my lap on my right.
oh,
Yeah, and that kind of like, I was so amazed by that, because it was at the same time that she said, imagine myself in 6 months where I'll be headed. And it was, when you talked about that, it's, she did, she mentioned that I will significantly see kind of transformations in terms of, the kind of the outcomes that I'll be feeling, the abundance, like after that session. And I definitely have felt it after that last weekend, in terms of aspects that have happened since then, which I'm not going to take up the time for our podcast to go into. But I just wanted to mention about that butterfly. And when I looked at it and it flew off, it was, for me, it symbolized like transformation. And
yeah,
the fact that you talk about that, what are the sort of, for me, again, state of flow, and like the kind of like that synchronicity, like, which I call godly interventions, like that. Here we are, you know, um, kind of like nearly a week into that experience, and you talk about that, going kind of like from
yeah,
the darkness to
absolutely.
light, and sort
Yeah,
of like, that.
really
So
powerful.
I just wanted to bring that up, because this is, I didn't plan it for things to have planned out that
Yeah,
way, and I
absolutely.
didn't think about it that, I didn't even know butterfly was going to come, but it just happened to be that, everything kind of connected. And I don't know whether you feel that in your life as well, but I really
Yeah,
I'm really in tune of about how. And for people that don't know what occupational therapy is, I would love to hear from you and from your lived experience, like, what is occupational therapy briefly? Like, it'll be great to know from
yeah.
your lived
Oh,
experience, your
I think
understanding.
I think for me, occupational therapy is about helping people to find their purpose, to live their purpose, and to feel joy doing the things that they love doing. And, and obviously through those things, through those purposeful occupations, it helps us with our mental and our physical health, with our relationships, with all of those things that impact on us day to day. And
Yeah,
the one thing that I really struggle with, Danuli, is people who say, I don't know how to describe what we do. And I
yeah,
just think, well, after 34 years, I should be able to describe it. But I think
yeah,
what it has done, it has transformed over the 34 years of having, I've been 38 years, I've been in the OT world. But I
mm,
think, I have grown, I have metamorphosized, what's
yeah,
the word? Gone
yes,
through a
absolutely,
metamorphosis
yeah,
myself, sort of personally and professionally. My plan
mm,
had never been to leave case management. I
mm,
did love my job, but as my perimenopause kicked off, I just couldn't stay there.
mm,
I had to spread my wings. I had to do something different for my own health and well-being. So I think,
mm,
I think that butterfly moth analogy is really important, particularly for midlife women,
yeah,
because we go through this huge hormonal shift
mm,
and it changes us. It
mm,
changes how our brains function. It changes our bodies, sometimes not for the best. But, we do become different people. And I
absolutely.
really feel like I don't feel that different in some ways to how I did when I was in my 20s, but I feel like that person with a whole heap of wisdom piled on
Mm,
top. And it's
mhm.
like, I do feel like I have literally been transformed. And
Wow, that's
it's quite
amazing.
a miraculous thing that happens. And I know we haven't talked about this before, but I think it's a good point to maybe just drop in and for
Mm,
people to think about. And it's one thing that sort of goes around in my head a little bit of, I wonder how people's experience of menopause changes when they're on HRT and they start that at a very early stage. If
mm,
they start to get symptoms and so they start HRT, I wonder how then that affects that
mm,
transformation.
that's a
I
really good
haven't got an answer,
question.
but I would love to
Yeah.
hear from people as to
So yeah,
what
people
their
can comment.
journey.
Please comment, ladies, you know, because
Yeah,
we want to know. Yeah, absolutely. And everybody's different experiences are so unique to them and their
yeah,
bodies and mind, isn't it? So yeah,
absolutely.
speaking of which, this is a really good segment to now go into the next part of the podcast, which is understanding women's health. So when people hear the term women's health, what does it actually encompass?
Well, it's a bit of a broad term, isn't it? I think generally when people think of women's health, they think of maybe a pelvic health physio and yes, pelvic health therapists. And I would like us to start and talk about therapists, not just physios, because
Hmm.
there are more of us stepping into this space. So, I'm saying occupational therapists, particularly in America, but there are a few of us trained in the UK now.
Hmm.
Um, Osteopaths and chiropractors actually stepping into the pelvic health space.
Hmm.
But women's health really is a branch of medicine that
Hmm.
covers a breadth of health issues that women will experience. So that could be gynecological care, pregnancy, menstruation, menopause, breast health, physical health. It could be sexual health, our mental health, and essentially as women we have a different biology to men, and I'm
Hmm.
talking about obviously biological,
Hmm.
and I don't want to exclude people who are transgender or
Hmm.
non-binary in this conversation, so
Hmm.
forgive me for using the word women, but I'm talking about anyone with a uterus.
Mm,
um, so yes, obviously metabolic health, cardiovascular health, anything that affects the woman. And we are
mm.
different because we have different hormones. And essentially we have a uterus, men don't have that. So yeah, it can encompass any and everything pretty much.
Yeah, absolutely. And many women actually assume symptoms like bladder leakage, pelvic pain,
Mm.
painful sex, or severe PMS, postmenstrual, symptoms are simply part of being a woman. W what myths would you most like to challenge?
I need to jump on a box right now and go,
Do it.
because none of these things are no should be classed as normal.
Mm,
They may be common, but it certainly doesn't mean that anyone with a uterus should suffer with these things. And I
mm,
think, I do struggle in that women's health is woefully under researched, it's under
mm,
resourced,
mm,
and the tide has to change on that.
mm,
But we are dictated often by big pharma and what they want
mm,
to put their money to, and
mm.
they'll research the things that essentially will help fund big pharma even further. So yeah,
We-
so that's one of my myths I would like to bust.
mm,
um, Another one which I would like to bust,
yeah.
which I see come up time and time again, is around the contraceptive pill and how that is dished out like Smarties,
Mm,
um, often to very, very young girls. And,
mm,
girls are experiencing their periods at a much younger age, some 8, 9.
mm,
Um, and well, I think, maybe I shouldn't get on that horse about why that is, but they're obviously they're struggling and they're
mm,
experiencing pain or discomfort, and often the fix, the magic pill, is to give them the contraceptive. And it just really, really worries me, because that's not the answer to resolving their health. In fact, you know, the long-term use of the contraceptive pill, especially from a very young age, it potentially will lead to infertility problems, ovulation difficulties, you know, mood disorders. There's been a lot of research coming to light recently about how the pill is actually causing psychiatric, you know, conditions, and it causes mineral and vitamin deficiencies. So if we're giving this to our young children, what are we doing for their future health and well-being? You know, ovulation is essential to our well-being, and if we're turning that off, it's a disaster waiting to happen.
Yeah, no, I love everything that you said there, and I really, you know, I'm a sort of strong, very strong advocate for, you know, non-pharmacological treatments, natural, plant-based, you know, herbal like remedies, you know, really getting our healing from nature, and you know, and yeah, unfortunately, big pharma, as you said, has so much money in it, and there are kind of like the research, a, a lot of the research is funded by pharmaceutical like industry. So I just think, you know, in terms of everything that I'm very passionate about, that we're advocating in the non-pharmacological sector, it's, you know, and the sometimes underfunded like sort of research into it, you know, it kind of adds up into um why people are not so educated about it, why people would think about going to the pharmacological intervention first before thinking about non-pharmacological interventions, you know. And I'm trying to change this kind of sort of, you know, thinking that actually, you know, we there's so much like evidence that shows, and there's so much lived experience, like you've just explained, that there's, you know, abundant benefits that you can get in terms of on in the non-pharmacological world. So yeah, I will always be a very, very strong advocate for non-pharmacological approaches. And I think, you know, as occupational therapists, we are so good at thinking about holistic non-pharmacological, you know, kind of interventions. You know, that's what we're really good at, and and that's what we're very good at advocating. That's why we are very good at advocating for it. So I wanted to ask you, could you explain what the pelvic floor is and why it's so important, and why so many women don't realize when it's not functioning well?
Well, in fact, I have a model just behind me.
Oh,
I
please,
can
like,
show
bring
you.
the model out.
Bring
Like,
the model out. Okay, I'll try
yes,
not to lose
and
all of my
close.
organs, which are sitting inside.
Okay, yeah.
But essentially, the pelvic floor is
If you can lift
assessed.
it up and
I
tilt
will
it
in a
forward.
minute. I will in a
Okay, yeah.
minute. Yeah,
I'm jumping
bear
ahead.
with me a second. So,
Yes, yeah, go on.
essentially, it's a set of 14 muscles that
Mm-hmm.
create a hammock in the bottom of our pelvis. So this is our pelvis. This is the back view, so you can see. So we've got our spine and our sacrum, and then the big ilium here. And so it essentially, what it's doing, it's creating a hammock which supports all of our organs inside. But if we look at the bottom here, so the 14 muscles, they're in 3 layers, and they run from sit bone to sit bone, pubic bone at the front here,
Mm-hmm.
to the tailbone at the back.
Mm-hmm.
So I'm just about to lose a part of my pelvis. But if I take that bit off there. So this is the tailbone. So you can see the muscles here running all the way down. So this is the anus, this is the vulva, and then this is the pubic bone. So essentially, they're creating a sling at the front and a sling from side to side.
Mm-hmm.
And if we think about the pelvis as being a bit like a fortress, you know, like a castle, you know, with its moat around, and its job is to keep things in. So obviously it's pretty important that it looks after our organs and it keeps those inside the pelvis so they don't fall out. And it obviously keeps hold of our urine, keeps hold of our...
I just had a thought in my head, the jewels in the fortress.
The jewels in the fortress. I love that. Okay, well, these are definitely jewels in our fortress.
Yeah.
So we're obviously hanging on to, so this is our bladder. So we're hanging on to the urine. If things don't work properly, you know, if they're too open, they're too lax, then we can't hang on to our urine. And our bowel, so this is the rectum right at the back, and just notice how close everything is together. So there's not a lot of space, everything is very compact in there. But essentially this fortress protects, keeps everything inside, and it stops us from losing its contents if it's working well. And then when we choose to, so if we go into a state of relaxation when we sit on the loo, we are able to open our bladder and we're able to open our bowel. So we're letting the drawbridge down, and then we can let the contents out.
Wow.
So it's all quite important. But also, aside from obviously the functions of peeing and pooping, it's vital for intimacy and sexual pleasure.
Yeah, I was just going to ask you actually. I'm glad you brought it up because this is a taboo subject that not many people talk about, but
I do lots of taboo. I'm happy to do taboo.
It's so important to talk about it. Let's talk about sex. Let's talk about sex. Right. So
But I think, sorry, go on. I'll let you speak, and then I'll tell you just a little bit more about the pelvic floor.
Okay, yeah. So I would love to know, and I'm sure our listeners would love to know, you know, after you've had children, and before you have children and after you have children, what are some of the sort of important things to think about, you know, in when we're thinking about our pelvic floor around, you know, is there certain exercises we can do? Like, is there, you know, how should women before they have birth prepare their pelvic floor to function as best as possible, and also afterwards? And obviously you've got lived experience because you're a mother. I'm not a mother yet. Who knows if I will be or not, I don't know. But I would love to know for our listeners out there, you know, that question around pre and post birth, like, and also around around intimacy as well, you know, kind of you know, I know that women can have a loss of sensation there as well, you know, after birth. Like, so what are some of the things, like strategies, tips, like advice that you want to give out to women out there around those things?
I think so it almost leads on in some ways to the next part of what I was going to say about how the pelvic floor works. So again, coming back to education, we need to understand how does this system work and how can we optimize it. And we need to understand that it's a pressurized system, and the pelvic floor actually doesn't just work in isolation. It works alongside the diaphragm, the transverse abdominis, which are the muscles in our tummy on the sides, and also there's a set of muscles called the multifidus that goes all the way down the spine, and it supports the spinal processes. So all of those muscles work together, but all of those muscles don't work without everything else. I'm waving my arms around. Our whole body is a system that works together. And so we can't just strengthen all of these 14 muscles or improve their function by thinking that all we need to do is just squeeze.
Right.
And so whether that's pre-birth or post-birth, we need to actually be able to work on our breath. We need to be able to facilitate a full expansion of our rib cage and a relaxation of the pelvic floor. Because without a relaxation and a lengthening, we can't strengthen. So what tends to happen is people think, obviously, especially post-birth, I just need to work on, you know, squeeze.
Yeah.
And what tends to happen is, and this is also happens pre-birth, so this is for anyone at any stage in their lives, we just work on what are called Kegels, which is squeezing exercises. If all we do is work on squeeze, 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 we can actually create what's called we shouldn't really call it hypertonic, but it does get used a lot as a hypertonic, but a high tone pelvic floor. So in other words, the muscles are just very tight. So if you have muscles that are in a really tightened state, you can't relax and let go. So when you go to pee or you go to poo, you end up constipated, or you're retaining urine and not fully emptying your bladder. So really the most important thing for women to think about is, how can they treat their pelvic floor and their bodies more like a jellyfish? So everything moving in a soft and a reflexive state rather than a squeeze, squeeze, squeeze state. So, if you think about a jellyfish as it sort of opens up and it relaxes, that's when we're filling our diaphragm, filling our lungs, and the pelvic floor softens and it descends. We need to be able to let go. And that's really, really essential for birth. It's not about pushing really hard in birth. We need to be able to soften and everything will open up. That's what you need for a baby to descend. So breath, always come back to breath and relaxation first. And then when we're thinking about the tightening element, so then think about the jellyfish coming back up and closing together. We want to do that in a way that is soft and reflexive. And in a way, if you think about this analogy of picking up a blueberry with your vagina, you're not going to squeeze really, really hard because you're going to pop your blueberry, aren't you?
Depends how hard the blueberry is.
Yeah, absolutely. We've got a nice plump ripe blueberry, and we literally want to bring that up with about 30% of our strength. And we want all of these things to be happening as we're doing our everyday activities. And I think that's the thing, as occupational therapists, we bring into the pelvic health picture. It's, how are people performing their everyday activities? When are they actually experiencing, say, incontinence? Is it when they're bending over to pick up the laundry? And so you can imagine, well, if you're doing that, that's because actually you haven't necessarily breathed properly, and you've bent over, and maybe you've held your breath, and so you can imagine then you're under pressure, and so that pressure's got to go somewhere.
So interesting. And when you talk about it, just made me reflect about, when you talk about occupations and our activities of daily living, and how the breath and our pelvic floor, and sort of, kind of how so many different muscles, not just in the pelvic floor, but it contributes to the health of our pelvic floor. It made me think of our everyday activities of daily living, like when we talk about occupations and occupational therapy, people get confused and they think we're talking about occupational health. Yes, occupational therapists like myself exist in occupational health and vocational rehabilitation, but occupations are essentially activities of daily living. So
the things that we do every day,
yes, exactly. So when you talked about the laundry there, and when we're talking about sex, that is a meaningful occupation for people, brushing our teeth, like washing and dressing, all of those things are meaningful activities. So because it forms part of our routine. And I guess in terms of, coming back to that intimacy and sex, because it is a meaningful occupation for a lot of people, what is your kind of, understanding and sort of, how women can like improve their pelvic floor around, post-birth, around kind of the sort of the muscles in there that you talked about, and also, the sensation, because after birth, my understanding is that a lot of that changes for women. So
for some, not everyone is different. So I think it depends on whether or not you've had a birth injury as well, or you've had an episiotomy. So an episiotomy is where they actually cut the perineum. The perineum is the space between the rectum and the vagina. So this area is usually cut either vertically or on a diagonal. So that obviously can, if you've have scar tissue, which you will have scar tissue after having any kind of tear or medical intervention like that. So that can cause a reduced sensation. So yeah, everyone is different, Danuli, but ultimately, in terms of one thing I would say to people, if they are struggling post-birth and their doctor says to them, oh, just wait and see if things improve, ignore that advice. You need to seek advice, and you can seek advice very, very soon after giving birth. In this country, we are woefully lacking at providing postpartum care. In France, everyone has their 6-week checkup. The mum is thoroughly checked. She has a full pelvic examination and the baby is checked. Here, you're lucky if you get someone say to you, oh, how are things? And then you're just expected to get on with it. And the same with C-sections. We're not sent out, you know, I've had a C-section, wasn't given any advice on scar care, how to look after my scar. And those experiences are highly traumatizing. You know,
Absolutely,
some women they have their elective cesarean section, so it's more prepared, it's more controlled. But you know, for many of us, it's an emergency situation, and it's deeply traumatizing.
Physically and emotionally, absolutely. Physically, mentally.
Absolutely. So
apart from the breathing, I guess kind of like, is there anything else you can think about, pre and post birth, that can make sort of sex enjoyable for people who've like lost that, the feeling of it being enjoyable because of the physical and emotional trauma that they've experienced from having birth. Yeah, it'd be great to know if there's anything else.
I think everyone needs to be individually assessed, and I think one of the huge benefits of an occupational therapist carrying out an assessment is that we're trauma informed.
Yes, absolutely.
Support people with the psychological side of obviously their situation, as well as the physical side. So ultimately, it depends on, potentially what is causing the difficulties for them. So say, for example, if it may be pain on penetration, and that's because, say, for example, they're very dry or they've had have a scar to deal with. So I would give advice around scar management. So I could treat the scar myself in clinic, but I can also give people information on how to self-care their scar at home. It may be that they require vaginal estrogen post-birth, and that's something really important to think about. So aside from vaginal estrogen being something that can be prescribed during menopause for vaginal atrophy, or what we now call genital urinary syndrome of menopause, bit of a mouthful, but we also have genital urinary syndrome of lactation. So if a parent is feeding their baby, they may start to experience difficulties with a dry vagina and vulva, soreness, red skin, and that obviously will lead to difficulties with penetration and comfortable sex. So whilst they're lactating, it's safe to use vaginal estrogen. And then there are other things that also can be considered. So whether or not having some internal work to release tension around scars or tension within tissue, or if someone is experiencing pain, to help desensitize those pain pathways. It may be that dilators might be helpful if there's restrictions in tissues. So ultimately, in terms of self-care, people need to obviously be thinking about that 360 breath, thinking about relaxing the pelvic floor, being able to elevate the pelvic floor, but not in a really tight, constricted way. And that all helps with increasing blood flow to the area, helps with control, helps with sphincter control, bladder and bowel management. And that's also the other things that people need to think about is their positioning on the toilet to help open their bowels, to avoid constipation. Constipation is a massive driver for urinary incontinence, and because it causes pressure within the pelvic floor. So as OTs particularly, obviously, you know, we can give that advice around bladder and bowel habits, positioning on the loo,
equipment,
equipment, nutritional advice, fluid
yeah.
intake, all of those sorts of things. So so there's a lot that can be advised or thought about, and it's obviously on an individually, you know, needs-led basis.
Love that. Such a practical tips, and obviously women breastfeed as well. So, you know, there's there can be pain around there, and
Yes.
yeah. Have you got any kind of thoughts around kind of breastfeeding as such? You know, kind of like
only
with
from a personal perspective, which was 20 odd years ago. I haven't worked with postpartum women who are experiencing difficulties with feeding, but you know, feeding is a beautiful experience. It helps you bond with your baby, but it can also be extremely hard. You know, you essentially you can feel like a cow because you're carrying this child, you know, and feeding continually. It feels like until they get a little bit older. And then that also can affect intimacy because, you know,
absolutely, yeah. And that's what I brought it up. Yeah, absolutely, because it can affect from a pain, physical, emotional, like all the different aspects, you know, that goes along with women's health. Yeah, and I love that you kind of you touched on such a kind of holistic way of talking about all of those practical tips. So in terms of the breathing that you described with the jellyfish analogy, would you kind of say to do that pre-birth and post-birth?
Everyone should be breathing like that all of the time.
So all of the time,
all of the time, you know.
Okay, throughout, okay. Yeah.
It's a really a good way to assess whether or not you're actually 360 breathing. So if you place your hands around your rib cage.
Let's do it now together.
Let's do it now together. So take a breath in. Are you actually feeling, and keep breathing, are you actually feeling your ribs expand into your hands at the front, at the sides, and at the back? Or do you feel like your breath is coming more from your chest? Or are you more of a belly breather?
There's so much to think about with the breath, isn't there? Because we don't, and we're always with the breath, but we generally neglect it.
But people aren't. Yeah, we have our breath with us, but we're not necessarily connected with it.
And this is so important to really, this is why I love meditation, breath work, because you remain present with, you know, really understanding like how your body's functioning. Love that. Thank you. So I will do some practice with that, and I will really be in tune with that.
One little tip is to use either a yoga strap around your ribs or just under your ribs, or a belt from your dressing gown, and just go about your day. So, you know, when you're doing the washing up, or you're loading the washing machine, or actually, what are you feeling? What are you experiencing? Are you aware of your breath? And I think as women, we are very bad at 360 breathing. And I've even worked with some yogis actually who think that they breathe really well. And actually they do a lot of belly breathing. And that isn't where we should be breathing. We might do that as an exercise to sort of bring awareness, or during breath work or meditation, but that's not where we should be breathing from all of the time. The belly or the chest should be ancillary. They just come in towards the end of a breath. So, and one of the reasons why we tend to be very poor at diaphragmic breathing It's because as women, we tend to hold on to our tummies a lot. We keep it sucked in because we've been conditioned to not let our tummies out because, you know, heaven forbid we should have a tummy on show. So that means that we end up breathing here. And so if we're breathing more from here, from our chest, then we end up with really tight shoulders, really tight necks. Our SCMs, our sternocleidomastoids end up really, really tight. And I see this a lot. Women coming into my clinic like this because they just don't know how to breathe properly.
Wow. And again, a life skill that we should be taught from a young age.
Absolutely. I mean, babies obviously know how to do it really well.
Yes,
but,
absolutely.
we start to lose
what
that ability.
Yeah, and that's why I really believe we should go back to our childlike self, you know, with play, with the way we laugh, with the way we breathe, you know. There's so much, you know, just beauty in terms of like the innocence of being like a child, you know, and the positives of it. But I love how you sort of brought the connection between the jaw, breathing, pelvic floor, and nervous system, and how you explained how so much things are interconnected, you know. You know, hormones affect far more than reproduction. How do you think they influence like our brain, mood, sleep, energy, memory, and ability to function day to day?
That's a very big question. I'm going to try and squeeze it into a very easy, digestible answer. Essentially, hormones are our messenger system, and they're integral in every single function that our brain performs. So they're responsible for our cortisol, adrenaline, and our stress system, our thyroid hormones, our melatonin, which helps us sleep, our metabolic system, you know, which obviously is our insulin and our glucagon, and then our sex hormones, which obviously most people think, oh, that's what our hormones are. So our estrogen, progesterone, testosterone, follicular stimulating hormone, luteinizing hormone, which obviously helps with our egg creation and fertility. And then, you know, we've got growth hormones, and we've got oxytocin, which is our love hormone, and vasopressin, which is our water balance hormone. So, you know, there are so many. That's just a short list, but there are probably hundreds of them. And you can imagine that if our hormones aren't functioning well, then they all impact on something else within the system. You know, they don't work in isolation. They all talk to each other. And I think a really good example, I know we've talked about stress, but, you know, if our stress hormones are very high, then we're going to have problems with sleeping and thinking clearly and remembering things, because our body is prioritizing safety over function. And stress is a particular problem for people who suffer with, say, premenstrual dysphoric disorder or premenstrual syndrome. But it's particularly a problem for those of us going through perimenopause, because if our bodies are prioritizing producing stress hormones, they won't prioritize balancing and producing our sex hormones. So our sex hormones, progesterone, estrogen, testosterone. And progesterone is a particular problem because cortisol will steal progesterone. It will steal it because it's on the same sort of pathway. It will pinch it because it needs it. And so you can imagine then, if we then don't have adequate levels of progesterone anyway, because it's declining in perimenopause, then we've got cortisol doing its, you know, burglary. Then we've got a limited chance of being able to actually feel regulated, feel calm, and to sleep well. So progesterone is that lovely calm hormone that helps us actually buffer when we have stress, and it helps us to sleep well, and it reduces anxiety, and it helps to balance our mood. It's also good for bones and our brain. So there's lots and lots of benefits to progesterone. So you can understand why stress management is really key for, you know, for my clients, because if you've got high stress, then your hormones are wafty. you know.
And why many women become confused around contraception, progesterone,
Right.
HRT, and hormone treatments. Like, what are some of the biggest misconceptions that you encounter, and why is personalized assessment so important? And then I've got another question around perimenopause I want to ask you, but let's start off with that because it's a
Okay.
loaded question.
Yeah, and it was quite big. So can you repeat it
So yeah,
again?
sure. So many women become confused around contraception, progesterone, HRT, and hormone treatments. What are some of the biggest misconceptions you encounter, and
Yeah.
why is personalized assessment so important?
This is a big topic, and we probably could do like a whole
Podcast on it.
podcast just on
Yeah.
hormones and contraception.
Mm,
I think for me, and I think this is a really important thing that I'd like to talk about, because
yes, yes.
it really frustrates me that there is a
Mm,
lack of understanding in the medical field around progestogens. So
okay.
I'll explain what they are. So
Yeah.
progestogens is the catch-all term for anything with a P in it. So
Mm,
whether that's progesterone, so which is our natural progesterone, whether that is progestin, which is synthetic form of progesterone. And I think this is really, really important for women to understand the differences. Sorry, I'm getting very passionate because I hear the term progesterone used interchangeably and often as well by the medical world. And actually we need to stop that. And it is confusing because obviously the catch-all term is progestogens, and then you've got progestin and progesterone. And so it does sound very confusing, and it hasn't been helped by big pharma, who have done a lot of research into progestogens, not so much into progesterone, and it's caused confusion in the
mm-hmm,
medical world. So
mm-hmm,
essentially what happened back in the 1930s, I think it was, they found that when they prescribed estrogen, the womb lining became thick. So the endometrium, which is the lining of the uterus, became thick, and women became unwell. And so they would bleed either heavily, or they would potentially develop cancer, obviously, if it's left unchecked. And so they found that when they took progesterone orally, that progesterone didn't really do the job that it needed to do, because the molecules were too big and it
mm,
has to go through the liver. So it's called first pass through the liver before it then goes into the bloodstream. So by the time it obviously, got where it needed to go, which for them, their priority was making sure that the uterine lining remained thin, there wasn't enough of it. It just
mm,
wasn't, it didn't help systemically.
mm-hmm,
So big pharma started doing all of their work around progestins, the synthetic form of progesterone.
mm-hmm.
And so a lot of the research has been around prioritizing and focusing on maintaining the thin lining of the uterine lining. But obviously what they missed in all of that research was the benefits of micronized progesterone. So micronized means that the particles have been made really tiny. So actually they then will pass through the liver and can be absorbed into the bloodstream, and then have a positive benefit on the uterine lining. So, but what they discovered in their research was that progestins alongside estrogen actually have a slightly elevated risk for breast cancer. What ended up happening was that got translated into all progestogens have an increased risk of causing cancer, and
Mm-hmm.
that's just not true. So it's the progestins which elevate the risk, but progesterone, micronized progesterone, does not elevate the risk. But unfortunately, the medical world have not delineated the differences.
Mm,
So I think it's just really important for women to understand that progesterone is synthesized by the body in a completely different way to synthetic progestins. And synthetic progestins are given as a priority to maintain the lining of the endometrium, but progesterone, micronized progesterone, is given, you know, has so many more benefits. So it supports bone health, brain health, it helps with our sleep, as well as working on the uterine lining, but it helps to balance our moods, it reduces anxiety, it helps with depression. So it has so many more benefits. But if you're taking a synthetic progestin, so if you think about sort of receptors being like little locks, so to speak, you know, the little progestin, the synthetic progestin comes along, clicks into the little lock, and then your natural progesterone has nowhere to go.
Wow.
And so for women who particularly are sensitive to progestins, that's why, because it's blocking your natural progesterone, and so it just floats off and you excrete it because it's surplus to requirements. And particularly if, you know, you're just thinking about the contraceptive piece that you mentioned, you know, contraception is given for a completely different reason to hormone replacement therapy. So contraceptives are a much higher dose of synthetic hormones, which will block your natural hormone level, your hormone production, completely turns them off, and replaces them with this high dose of hormones, synthetic hormones, for the primary purpose of stopping you from getting pregnant. But hormone replacement therapy, particularly if it's body identical, so it matches our normal, you know, our regular hormone production, then, and it's obviously naturally made from yams, then that is at a much lower level, and it's prescribed to support your own natural production. So it's not cancelling it out unless it's a synthetic form, and then it fills the receptors.
That's so useful, and I love your detailed explanation, because gosh, I've learned so much, and there's so much that we don't know, isn't there? Like, you know, and I think that's the same with, you know, products, food, like so much we put into our bodies
Yes,
that we just
absolutely.
take it, and we just don't know the adverse effects that it's having, like, you know.
Like huge. So I mean, we are
Yeah.
living in a toxic world, and
Gosh.
we are absorbing what are called xenoestrogens. So they are pretend chemical estrogens from our environment all of the time. So
Yeah.
if you've applied perfume today,
Yeah.
or you've applied a moisturizer with a fragrance in it, or a shampoo with a fragrance and parabens and an SLS to make it all soapy, all of those things act as
Absolutely.
xenoestrogens. If you
Yes.
cook your ready meal in a plastic tub that it comes in,
Absolutely.
plastic xenoestrogens are leaching
Oh
into your
gosh.
food.
Yes. Oh, I am so like I try to be so mindful and conscious of, you know, I got rid of my microwave, for example,
Did
because,
you?
you know, yeah, and that there's just the I always read like what's on the ingredients of products and food, and
Yeah.
because I'm really mindful of what goes in, you know,
Yeah.
and because
Really
like
important.
you're talking about all these things. It made me reflect on how our bodies will, if there's a foreign sort of you know, system that goes in our bodies, it doesn't like it and it'll reject it, and it's like our body's way of kind of saying, no, I don't agree with this, you know, and it's because
Yeah.
it's stopping the natural cycle of
Yeah.
what our bodies are supposed to do, and I just think so much synthetic and man-made um things generally can be anything that is made that
Exactly.
doesn't align with the way our bodies want to live, you know.
No,
And
exactly.
when you look at nature, that's why I just love nature, because in you know when you take nature at its most natural, and when it's not man-made, it's just so beautiful, and there's so much to learn from nature, you know.
Yeah.
And how this is it's whole ecosystem in itself, how animals interact with it, and how we interact with it. It's just, yeah. But I wanted to ask you, what actually happens during perimenopause, and why do so many women not recognize what's happening?
Well, I think we're living in such a busy society now, and I think there's a mixture of things that are happening. I think we've got women who are leaving it later to have children.
Mm,
They're at the height of their career,
mm,
and often they'll put down maybe what they're feeling or experiencing down to just being busy.
mm.
And then we've also got, these poor women because of their age, they're also caregiving to their
Yes.
parents, or, so this
Yeah.
sandwich generation that they love their career, they love what they're doing, and they're not, and obviously they've got their young family potentially caring, and where do they fit in? Where do
Mm,
they look after themselves? And
mm,
so I think self-care often goes out of the window.
mm.
And self-care isn't a bath. We're talking about even just basic nutrition, not
Yeah.
sleeping properly,
True.
basic things actually to keep us well and alive and
Mm,
functioning properly start to
mm.
drop off the perch,
True.
because they're just, and I think we've almost become a bit of a victim of our own success, haven't we, as women?
Yeah.
We
It's
want to
true.
work, we want our careers, we want our children, and we end up trying to juggle it all.
Yeah.
And
Yeah.
so I think there's an element of busy, busy, busy. And I remember wearing that busy badge of honor myself. It was so detrimental. And then the element of maybe not being aware or understanding, coming back to that life cycle piece of not knowing
Hmm.
actually what is this that's going on. Because in the very early days, women might just find that actually, well, they've just got to, their PMS is a little bit worse, or
Mm,
they're not sleeping quite so well, or they might be feeling a little
mm,
bit tired, so they feel tired, so they put that down to not sleeping. And so it's
mm.
easy to find reasons for why they might be feeling the way that they are, but missing that hormonal piece, that actually, because they just
Yeah.
don't have that information.
And what actually happens during perimenopause then?
Well, so perimenopause, that's a lot. It's a big stage. But
Yeah.
perimenopause essentially is that transitional phase leading up to menopause, and it can last on average from 4 to 10 years. I think mine was longer than that, actually. Um, but there are 4 phases that occur within that transition. So you've got the very early perimenopause. The periods are still regular, but progesterone is potentially starting to lower. And some women, if they are aware and they understand what's happening, they think, oh, could this possibly be? And they might visit their GP, and their GP goes, oh, no, you've still got regular periods. Well, actually, that doesn't mean that you're not in perimenopause, because your periods are still regular at that very early stage. Then the next stage is the early menopause transition, and that's when the onset of irregular periods may start. And it might just be a day here or there. You might have had a 28-day like clockwork cycle, and then you find, oh, it comes a day late, or it might come a day early, and then it might be 2 days late, and then things sort of start to get a little bit
Mm,
erratic. And
mm,
then we step into the early menopause transition, and that's when, oh no, I've already said that. Then we've got the late menopause transition, which is
mhm,
when you experience your first cycle of 60 days. So essentially you
mhm,
miss a period. So that's when
mhm,
you're starting to head into that late perimenopause.
mhm.
And then no, the late, it's really confusing because it's late menopause transition, and then it goes late perimenopause. I don't
Mm.
understand why they've come up with those terms and it all gets mixed up. So the
Mm-hmm.
late perimenopause is basically when you're 12 months away from your final period.
Right.
And menopause is when you haven't menstruated for 12 months. So essentially, the late perimenopause, because it's 12 months from your final period, you don't actually know whether or not you're in late perimenopause, because you
Mm.
don't know when your last period's going to be until
Mm.
you've gone 12 months. It's
Yeah.
really
Yeah.
confusing. So
Yeah.
you've basically gone 12 months without a period. That one day, that birthday, if you like, of lack of menstruation for 12 months signifies menopause. Just one day. The
Mm-hmm.
next day, you are then postmenopausal.
Mm. So interesting.
Yeah.
And uh, yeah, go on. What
No,
were you
it's
going to say
fine.
something?
So yeah, going back to sort of why, I mean, yeah, I think you can imagine, because, well, you know, that phase lasts for 4 years. For some people it might be 2, for some people it might be 8. Actually, you know, it can be a little bit confusing as to where actually are you, certainly towards the end or even at the beginning. But I think for women to understand that actually perimenopause can start at any time, but particularly for most women, they might even start to notice slight changes from their late 30s.
Mm.
So basically, as we hit our late 30s, our progesterone starts to go on a very slow decline. And
Mm.
some people don't notice it because they brush it off, because they just think, oh, well, they're busy or they're stressed. And yes, stress will contribute to obviously your progesterone being stolen, remember. But I hear women so often, like maybe around their early 40s, they go to their GPs and they say to their GP, I think I might be perimenopausal. And they do,
Mm.
one of the first questions is, oh, well, how are your periods? Oh, well, no, I'm 28 days on the dot. Oh, well, you're not perimenopausal. And that
Mm.
doesn't mean that they're not experiencing
Right.
perimenopause. And I
That's
think
so interesting. I didn't know there was all these stages. So just to recap, those 4 stages you
four,
said. So can you
four
recap what they
stages within perimenopause.
within perimenopause, and those are
Yes.
again?
So we've got very early perimenopause,
Yes.
early
Early.
menopause transition,
Yes.
late menopause transition, and then late perimenopause.
Okay. Very interesting. And there's yeah, it's so interesting within just that there's so many stages within and
I
I do
know.
when we were talking about kind of like women having children later in life, I was just reflecting on
Yeah.
how, the societal construct of successful women, in terms of their career and like not and kind of like not being in tune with what is happening from what we talked about with just the simple things around our breathing, our nervous
Yeah.
system, like and all the stress we're putting into our mind, body, and soul, like um and all of that does affect kind of like our women's health
It
really around
does.
that, and our hormones
It
and
does.
the way we regulate ourselves and I just the concept of like, oh, women can have it all, like, I do wonder whether this is a detrimental like concept for women, because kind of
Mm,
like to feel that they need to push themselves so hard for their career, and then they need to push themselves so hard being a mother, and like just juggling so many occupations, and
yeah.
then obviously then a partner to someone, and you've got family responsibility. There's just the amount of responsibilities that
But you can
that
understand, can't you, why you hit that sort of perimenopause
yeah,
window in your life
yeah,
and you start to unravel.
yeah,
Things start to, past traumas,
yeah,
stressors that you've had, just
yeah,
things start to bubble up, and
absolutely,
it
yeah,
becomes a really tumultuous time, because I
yeah.
think I think we have just, yeah, we're carrying too much, and it's got
And
to come out somewhere, hasn't
yeah,
it?
And on that note, many women tell themselves they're simply stressed, anxious, or not coping. I'm sure you hear a lot of that from your clients. Like, how do you help them understand what's really happening? Like, so that's the final question in this part of the podcast before we move on to the next part, which is, which will fit in like neatly into, nervous system regulation and lifestyle medicine. But yeah, around just to kind of finalize on this part of the podcast around the question around, many women tell themselves they're simply stressed, anxious, or not coping. Like, how do you help them understand what's really happening?
The first thing I do, I come back to listening, always listen, because actually they are stressed, they are coping, they are dysregulated, their stress levels are high, and it's being able, and I think that's our secret sauce as OTs, that we are problem solvers, we're detectives, we help to investigate with our clients. And I think being able to help them unpick what the root cause of something might be. So is this hormonally driven? Is it that actually you may be in this perimenopause window? Or is it that actually you have just got too many piles of stuff on your plate that you're having to juggle? Or is it a mix of all of these things?
Yeah. And do you tend to see some of the like what are some of the most common symptoms that women present with before they realize hormones may be contributing?
Often it's sleep. So
Right.
sleep will become dysregulated, and also PMS symptoms may either start or become exacerbated. So, and that's because of that progesterone that is starting to go on the decline. And a lot of the narrative around our hormones changing at this time, often from big pharma, but I also hear lots of doctors as well. They all talk about estrogen and how estrogen is the hormone that is deficient. And actually, I really want people to understand that it probably isn't estrogen in these very early stages. It will
Right.
be progesterone, because that is the first hormone to start to decline. In fact, testosterone starts way earlier in our 30s, but we tend not to notice it quite so much. But
Yeah.
progesterone is the key. So if you're starting to feel that you're a bit anxious before your period is due, you're feeling irritable, just a bit, edgy, or you're feeling a little bit low, just not coping quite as well as you used to, and that becomes a bit of a regular pattern. And then your sleep may start to not be quite as deep and restful. And in the earlier stages, maybe sort of once you get into that sort of second perimenopause stage, then you might start to experience some night flashes. So doctors will often go, "Oh, you're experiencing hot flushes," and you go, "No, I don't have any hot flushes." But I remember waking up in the middle of the night, absolutely drenched in sweat, freezing cold. So
Wow.
I wouldn't have said I was having hot flashes because I was waking up cold and wet. And I remember there was one time I was awake when it happened, and it was the most bizarre feeling. Literally, it was like this heat just rose all the way through my body. And I
Wow.
just, obviously, and then, your vasomotor system then goes, "Oh, you're really hot. You need sweat to cool down." And then I was just absolutely soaking wet. And I was like, what
Wow.
on earth was that? It was horrible, and it made me feel really, really anxious. So that can actually be one of the earlier signs that women actually notice that they're just waking up drenched,
Wow.
freezing cold, because they're not obviously catching that early part of the vasomotor response. So yeah, I think if we can get women tracking and tuning in starting to actually just make little notes about what's happening for them, and start
Yes.
to encourage them to be a little bit more aware about what's happening. And then that helps them to really understand, well, actually, what is going on for me right now? Is this hormonal, or is it related to stress? And so it doesn't matter whether that stress is because their hormones are lowering, or because actually they've got lots on their plate. We've still got the tools to be able to support them with that.
Love that. Do you see any other common symptoms apart from sleep, and what you've described, or is that kind of like what you've described, the most common symptoms
In
that
the
you
very
see?
early stages, so
Yeah.
sleep, mood,
Yes.
and sort of premenstrually,
Yeah.
and then as things progress a little bit, you might find that actually periods start to become a little bit heavier as
Mm,
well.
mm,
Some women experience some significant clotting,
mm.
and their periods can last longer. For some women, their
Yes.
periods can become shorter.
Yeah.
So yeah, everyone is different, but usually they become heavier and longer, and then they start to reduce. And that was certainly my personal experience as well. They were heavier
Mm.
and longer, and I struggled to even leave the house. So, and I was lucky I worked from home, so I could manage that. But
That's a really
um,
good point, because if you have to go and travel into the office and, be in an environment with other people, that's really hard to manage, isn't it? Like, and regulate yourself when you're in kind of an office environment. Well, thank you so much for this. Yeah, this so far, we've done so great. And our next part of the podcast will be around nervous system regulation and lifestyle medicine.